of Kenyan medical students from XYZZ Med is a vibrant community of Kenyan medical students from multiple universities, united by the mission to enhance medical education in Kenya. This initiative is driven by the need to create accessible, locally relevant, and tailored resources that directly address the country's unique healthcare challenges. The current medical education system in Kenya frequently depends on foreign resources, which may not always align with the local context. This gap may leave healthcare professionals less prepared and contributes to a lack of public awareness regarding various medical conditions. XYZZ Med is bridging this divide by developing a wide range of educational tools, inducing relatable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, and etc. One such initiative is the CME series, designed to promote peer-to-peer learning, as it's often our peers who can break down complex concepts into understandable terms. Today's CME topic is breast cancer, and our speakers are, drumroll, Mohamed Onyango. I am just continuing 1 second. Yeah. Mohamed Onyango is a sixth-year medical university at the university. Mohamed Onyango is a sixth-year medical student at the University of Nairobi with a passion for medical research, anatomy, and global health. He holds a bachelor's degree in human anatomy and is pursuing a postgraduate diploma in clinical research and medical writing from James Lind Institute. He served as a demonstrator of human anatomy at the University of Nairobi for 6 years and as an associate editor of the Journal of African Medical Students since 2022. He is actively involved in leadership roles, including as Africa Student President of the International Collaboration and Exchange Program at Columbia University. His research interests span anatomical variations, clinical research, and mental health, and he is committed to mentoring students and advancing research initiatives. We also have Dr. Wangari Kinyanjui, a newly minted medical doctor who is passionate and a creative problem solver who makes the most of life. With a deep appreciation for the arts, she balances her love for creativity with her commitment to health. Wangari is the founder of Warrior Glow, a supportive initiative for cancer patients. She is excited to explore preventive and promotive health with a special focus on non-communicable diseases. And I'm the moderator today. I'm a fifth-year medical student with a passion for all things surgery, and I hope you enjoy this session. Mohamed, you can take the floor.
Thank you very much, Deepa, for that elaborate introduction to what XYZZ stands for, and just basically introducing myself and Dr. Wangari. For some strange reason, I thought it was auto-generated at some point, but yeah. Anyway, good. You able to see my screen?
Yes, we can see it.
Perfect. Yeah, so I have to apologize in advance. There's some construction that's happening just behind where I'm seated, so this might interfere with my audibility, but then let's see how we work around that. Now, October is Breast Cancer Awareness Month, and Felix and I thought it fit that this session would be dedicated towards breast cancer, and we'll see shortly why exactly breast cancer is significant and why we need to understand how to diagnose, how to handle patients who present with breast lumps, and highlight on the treatment and management options for patients with breast cancer. I might not going into the specific details of the treatment, but then I'll highlight basically schematically what the algorithms state, and different guidelines state different screening methods based on the countries you will eventually practice in. So generally, this presentation is to give you an overview of what breast cancer is, how to diagnose it, the basics, and how to manage your patients. All right. Now, as I said, I really need to highlight the why exactly we're doing this. Yeah. Now, I'll give you statistics of global statistics, and then I'll give you local statistics. I usually find it fit to have contextual statistics as well as global statistics because you're training to be global physicians. So it's important to have both aspects covered. Now, breast cancer stands as the second most common cancer worldwide. And when it comes to the mortality related to breast cancer, especially in Kenya, it comes second to cervical cancer. Um, when it comes to when exactly women experience or develop breast cancer, the peak incident usually occurs in postmenopausal women, especially in women over 65, and this is globally. And 1% of patients who present with breast cancer are usually male. So the 99% of the other patients are usually female, with a female to male incidence ratio of 125.8 to 1. So it's not uncommon it is uncommon to have males with breast cancer. So it's possible that males could actually have breast cancer. Now, according to global statistics, it's high in women of European descent. And when it comes to African Americans at a high risk for triple negative breast cancer, and we'll see shortly what triple negative breast cancer is. Now, triple negative breast cancer would then necessitate chemotherapy as opposed to having, hormonal targets and endocrine targets. So if you look at the epidemiology of breast cancer in Kenya, according to GlobalCan 2022, you'll see that breast cancer, in terms of the number of new cases, the incidence of breast cancer in Kenya was 25.5% amongst all the cancers. And you can see that is probably the single most leading cancer in females. And if you look at both sexes, it's still the leading it's leading in terms of incidence at 16.2%. So it's quite significant, and we really need to understand what exactly it is so that we manage our patients appropriately. Now, I am an anatomist, so I have to speak on anatomy. And the breast is a modified sweat gland that sits on the anterior chest. It's usually found between your pectoralis major muscle, which is this, and the subcutaneous tissue. Now it extends from the second to the sixth rib, and the nipple in males anatomically is usually located at T4. So on surface anatomy, there's a nipple, and then around it, there's this hyperpigmented area known as the areola. If you're to look at the parenchyma of the breast, it extends into the axilla. So we have an axillary process, something we call the axillary tail of Spence. And very many cancers hide their way in the axillary process. So it's very important as you examine patients who you suspect to have breast cancer, that you examine all the way to the apex of the axilla to find if there's any lump or lymphadenopathy associated with breast cancer. So the breast anatomically is divided into 4 quadrants. So you can divide it into, so in this case, this is the left side. Okay, this is the left breast, yes. So these are what I prefer using. So you have medial and this is lateral, then this are your upper quadrants and these are your lower quadrants. So that's how you divide it into those 4 quadrants. So again, this is your axillary process, and this is the blood supply of the breast. Now, a huge chunk of the blood supply of the breast comes from the internal thoracic artery by the second, third, and fourth perforating branches, and also from branches that come from the second part of the axillary artery. Now, you notice we also have nerves here. You see how your fourth intercostal nerve, the long thoracic nerve, is usually very closely associated with the breast. And this anatomy is important, particularly because post-surgery, we may have complications in these patients, things like winging of the scapula that we learned in first year. So you can see your breast tissue there. This is your pectoralis major muscle, and then this is the parenchyma of the breast. So if you're to zoom into the parenchyma of the breast, you notice that, so this is the nipple. Then opening at the nipple, you have these openings of the lactiferous. duct. So the lactiferous, so you have your lactiferous sinuses there, then your lactiferous duct. So this is your duct there. These are your ductules, and then this is a lobule. So this is a lobule, and then this is a duct. Why this is important is because when it comes to the pathological classification of breast cancer, it's important to know what exactly a duct is and what exactly a lobe is, or a lobule is, because that then forms the basis of invasive ductal carcinoma or invasive lobular carcinoma of the breast. So you have your duct here, you have your extralobular terminal duct. Then within the lobule, you also have a terminal duct. We call that the interlobular or intralobular terminal duct. Commonly, you'll find the term being used as TDLU. That's the terminal ductal lactiferous unit. And this is what it basically is. This extralobular terminal duct and the lobule. And the lobular, sorry, L is lobular unit, not lactiferous. So that's your TDLU. Lymphatics are also specifically important, as we'll say clinically. Once you dissect out some lymph nodes, the lymphatic flow is affected, and these patients might present with lymphedema. Now, clinically or surgically, these lymph nodes are divided into level 1, level 2, and level 3. Anatomically, they're usually divided into your anterior pectoral group, which are these ones. Then you have your subscapular group, which should be your posterior ones. Then your lateral group should extend all the way to the upper arm, so your lateral group. Then you have your central group, and then finally your apical at the apex, apical group here, your apical group. So those are the 5 main lymph nodes we look at anatomically. But surgically, you have your pectoralis minor muscle here. So those lymph nodes that are lateral to pectoralis minor, these ones here, are level 1. The ones posterior to pectoralis minor, that's level 2. And those medial to pectoralis minor are level 3. So that's how we categorize the lymph nodes surgically. So what then predispose women to breast cancer? So we have hormonal factors. Hormonal factors here mean prolonged exposure to estrogen. So this could mean early menarche or late menopause or nulliparity, or fewer pregnancies. So multiparity will be a protective factor. So if your period of exposure to estrogen increases, then that predisposes you to developing breast cancer. Individual risk factors include advanced age, that's greater than 65, sex here being female, ethnicity, as I mentioned earlier, and lifestyle. Lifestyle here means those who take food that's rich in fats and low in fiber are particularly predisposed to developing breast cancer and very many colon cancers as well. We also have some genetic conditions that predispose you to breast cancer, like Leigh-Frumani syndrome, Pew-Jaeger syndrome, and Klinefelter syndrome. Medical history also predisposes you to breast cancer. So if you have previous breast cancer of the, let's say, the contralateral breast, or benign conditions like LTIS could also predispose you to breast cancer. And then you have environmental factors, exposure to radiation therapy, exposure to previous chemotherapy for whatever reason, and other environmental factors would predispose you to breast cancer, just like any other cancer. Now, hereditary factors are particularly important in developing breast cancer. Now, we know the genes that are attributable to development of breast cancer. That's BRCA, breast cancer associated gene 1 and 2, BRCA1 and 2. Now, if you find, for those cancers that are hereditary, yeah, about 90% of those are attributable to these genes. And those are just for the hereditary breast cancers. But if you look at cancers in general, only 5 to 10% are hereditary. So this notion of, having BRCA1 and BRCA2 is, I mean, yes, it's attributable to breast cancer, but then you need to note that only 5 to 10% of breast cancers are actually hereditary. So we also have this other syndrome that I mentioned that could predispose you to breast cancer. And for those who have mutations in these genes, their increased lifetime risk increases up to 60% for those with BRCA1. And men, particularly male breast cancer, has been linked to BRCA2 mutation for those who develop male breast cancer. So if you were to largely categorize breast cancer, we could categorize it as either being non-invasive carcinomas or invasive carcinomas. And when we talk about non-invasive carcinomas, these are those cancers that do not breach the basement membrane. The moment it breaches the basement membrane, it's now invasive, because it could have lymphovascular infiltration, it could metastasize via the lymphatics to the surrounding lymph nodes, or even hematogenously. So if you were to remember the simplest classification, you have non-invasive and invasive carcinomas. So non-invasive carcinomas, we'll start with DCIS. So this is ductal carcinoma in situ that's confined to the ducts with no invasion. Now, if you're to do a mammogram on these patients, you'll see some microcalcifications. Remember that within the ducts and the different subtypes of DCIS. It's very high risk of developing invasive carcinoma, and a subtype is known as comedocarcinoma, where if you to look at it under a microscope, it has an area of central necrosis of death. Treatment, we'll examine treatment options later, but then we have breast-conserving surgery. So this includes lumpectomies and partial mastectomies. Yes, when it comes to breast-conserving surgery. Now, there's also LCIS, but I'm not cover LCIS because it has been categorized and it's no longer thought to be a precursor to invasive carcinoma. So it's usually discussed as a benign condition. Now, invasive ductal carcinoma, or otherwise known as IDC, is a common type of breast cancer, the common type of invasive breast cancer, and this accounts for up to 80% of invasive breast cancer. It forms very aggressive metastases. When it comes to metastasis of the breast, the mnemonic is usually 2 L's and 2 B's. So it can either metastasize to the lungs, the liver, the brain, or the bone. But then it can virtually be found in any organ. So if you're to find a patient who has a MET and the female, and you're asked what could the primary tumor be, an easy answer could always be the breast. Now, typically, IDCs are usually unilateral, found on one breast, and unifocal in one particular quadrant. And it may present with a palpable mass with some skin changes or nipple discharge. And we'll look at treatment options shortly. Then we have invasive lobular carcinoma. So this is carcinoma that's found within the lobules that we saw earlier. And this accounts for 10% of invasive breast cancers. They are less aggressive than ductal carcinoma, and they're frequently multifocal and bilateral. Presentation-wise, they usually present with ill-defined masses and skin changes, and treatment is often similar to IDC, and I'll show you that shortly. Now, other types of breast cancer include medullary carcinoma, and this is most of the time, if it's when it's stained and when cytogenetics are done on the tissues, it's often BRCA1 positive. It's really well circumscribed, and it's triple negative. We have mucinous carcinoma that's typically seen in older women and is well differentiated, and tubular carcinoma that's rare. It's well differentiated but has a better prognosis. And a papillary carcinoma, and this is anatomic pathology wise in terms of what you're seeing under the microscope. That's common in non-white women and expresses estrogen receptors. We said estrogen receptors, progesterone receptors, and epithelial markers like HER2 are prognostic markers for women who have breast cancer. Then you have a micropapillary carcinoma that's aggressive and often lymph node positive. So what are the clinical features of breast cancer? So we've already talked about the classification, what you'll see under the microscope, but then what would a patient come with? Most of the time, they're asymptomatic, and it's often detected by screening. That could either be breast self-examination or a mammogram or MRI, depending on how dense the breast is. So you have a palpable mass. Most of the time it's firm with poorly defined margins. You may have nipple changes, things like inversion of the nipple, discharge, or ulceration. And can even have skin changes like pudor orange, and I'll show you an image, retractions or dimpling. And then lymphadenopathy. So you'll find you have firm enlarged nodes. So basically, if you find a mass within the breast that's tethered to the underlying pectoralis major muscle, and it's firm, it's single, there could be multiple of them, it's suspicious of breast cancer. So what do you do in physical exam? So preliminaries is a mnemonic called help. So you basically introduce yourself to the patient, ask for consent, and if you're male and even female, you may want to ask for a chaperone. You want to adequately expose the patient from the waist up, including the axilla. And so you have good lighting, and then position the patient at a 45-degree angle. And also always ensure that, within the room, there's privacy and the patient is comfortable. Now, on inspection, what do we see? So generally, the patient might be cachexic. They could have jaundice, and jaundice is now when they have a massive liverment or several liverments. Could have pallor, so anemia, or breathlessness if you have a lung metastasis. Now, you notice that the breasts, depending on the size of the lump, might be asymmetrical with some contours or visible lumps, and I'll show you images shortly. So you want to inspect for any scars from previous surgeries or procedures, biopsies, FNACs, but FNACs might probably not leave any scars, but maybe a corneal biopsy would. So you have the breast. Now you want to examine the skin changes. So first, you want to check for fixation of the skin to that mass. You want to check if it has that orange peel appearance, a pudgy orange. Then you want to check if there's any ulceration, if there's a retraction, of the nipple, or if there's erythema. Now, erythema is when there's this reddening of the breast when it's warm, which may be suggestive of another subtype of cancer known as inflammatory breast cancer. Now, IBC, inflammatory breast cancer, has a very poor prognosis. So you need to make sure that the skin is well examined and well documented. So this is a case where you have a palpable mass there. So as you draw this, as you report this, a patient has come, they have a palpable mass. Remember to just briefly draw the breast, then divide it into quadrants, say there's a palpable mass, measure it, say it's this centimeter by this centimeter, then describe it. You may have enlarged axillary lymph nodes like that one there. You can see that's a pectoral lymph node. You can have skin retraction, like in that case. You can have nipple retraction, like in that case. You can have nipple discharge, and discharge that's bloody in nature is usually suspicious of malignancy. And you can have this orange peel appearance because the Cooper's ligament that attach the breast to the underlying fascia of pectoralis major are infiltrated by the cancer and contract. That's why it looks like so. So you have inflammation, that's suggestive of breast cancer, and then now when you have the whole breast being invaded, the carcinoma. So nearly 7 Ds to inspecting the nipple. So you could have discharge, and I say blood stain discharge is usually suggestive of malignancy, and to check deviation of the of the nipple, which could be due to an underlying lump. We want to see if there's D depression is basically for the nipple retraction due to the underlying tumor. Distraction could mean like the nipple puckering. That's also distraction that's indicated the breast cancer. You could have discoloration of the nipple. You could have displacement of the nipple or dermatitis. And all of these fall under Paget's disease, which resembles an eczema rash. So you have your breast lump, and now you need to categorize it. So you need to tell us the shape. Roughly, is it oval? Is it circular? Is it irregular? What does it measure? Is it 3 centimeters by 2 centimeters, 1 by 2, 4 by 6? We need those measurements and specify where exactly what quadrant and how far it is from the nipple. You want to, and as I said earlier, you want to examine the overlying skin for any warmth, any erythema that indicates possible inflammation. Is it tender or non-tender? Typically, most of these breast lumps that are cancerous are non-tender. The surface, yeah. So you want to check the surface. Is it smooth? Is it nodular or irregular? The margins, are they regular? Are they smooth? Are they irregular and ill-defined? Consistency, is it soft, firm, or hard? If it's firm and hard, again, suggestive of breast cancer. Fluctuance, is there absence or presence of fluctuance? Tethering, is it tethered to the overlying skin or the underlying muscle? Is it fixed? So that's fixation there to the underlying muscle. So what you need to do, you'll tell the patient to hold their hips, yeah, and then as they do so, this contracts pectoralis major, and then you're able to see whether it's fixated to the underlying pec major or not. Yeah, so that's the mobility. So lymph node examination, so you want to start with the normal side. So let's say a lady comes in, they have a lump on the right side, so you want to start with the left side. So you want to palpate the axilla gently and systematically, and you palpate all the 5 lymph node groups: anterior, posterior, medial, lateral, and apical. So when it comes to a clinical setting, you have to use the anatomical method, but then surgically, then that's different. So as you find your enlarged lymph nodes, you want to count how many are they, where are they, what's the size, are they tender, what's the consistency, and are they mobile? So again, here you have your apical or your subclavicular lymph nodes, your anterior group or your posterior or your pectoral, lymph nodes, your posterior subscapular, your central nodes, and then your lateral nodes. So you want to document whether each of these are palpable or not, just so that you have a comprehensive axillary lymph node examination. And remember, as you palpate the breast, you're palpating all the way to the tip of to the apex of the axilla. This is the parenchyma of the breast, yeah, in addition to the lymph nodes. So as you complete the examination, please remember to palpate the supraclavicular and cervical lymph nodes. Remember how lymph flows. So it flows from the axilla to the supraclavicular to the cervical lymph nodes, and then they'll eventually drain into the lymphatic trunks. You also want to examine the lungs. Are there any signs of pleural effusion? Is it stony down? Yeah. You want to percuss the spine. Is there any signs of bony tenderness, metastasis? You want to examine the abdomen for hepatomegaly, liver mets, and then obviously thank the patient and cover them appropriately. So distant mets, where could breast cancer metastasize to? So I said earlier on, it could metastasize to the bone. So patient will come in, they have a lump and they have bone pain. They could have pathological fractures or spinal compression. It could metastasize to the liver. So you can see these areas here. These are mets of the liver. Another one is here. Yeah. Another one is there as well. Lung metastasis. So patients will come in the cough, dyspnea, and hemoptysis. So you can see in this case, this is a pleural effusion. So here, there's a pleural effusion there. And there's another one here as well. All this is fluid. Yeah, good. Then brain metastasis. You have a headache, seizures, and focal neurological deficits. Okay, we have this subtype of breast cancer known as Paget's disease. Now, Paget's disease is, if you think about it, I mean, it's not that well understood, but basically what happens is normally you have a patient who has an invasive carcinoma, most of the time ductal, and then these cancerous cells migrate through the lactiferous ducts, invade the epidermis, yeah, of the nipple and the areola. And as they do so, they interfere with that epithelial integrity. Now, because of that's why we have these crusts, because we have fluid leaking through, we have inflammation. So basically, the pathophysio is you have a metastasis from a DCIS or a DCIS or invasive ductal carcinoma. They migrate through the lactiferous ducts and then invade the skin of the nipple and the areola. Now, because of that invasion, it interferes with the epithelial lining, and that's why we have fluid leaking through and this crust developing. So it looks like eczema-like. So it's a rare type of breast cancer that affects the nipple and the areola. You can see in this case, the nipple is almost completely destroyed. Yeah. You can see it's red, it's scaly, and the nipple usually has this blood-tinged nipple discharge. You can see this blood somewhere here. So Paget's disease is usually associated with an underlying DCIS or IDC, as I said, and diagnosis is usually made with a punch biopsy of the nipple. Treatment typically involves BCS, where you spare or you conserve the breast, mastectomy, you can do radiotherapy and or chemotherapy, depending on the extent of the disease and the underlying cancer. Now, IBC, the most dreaded type of breast cancer, it's rare but very aggressive because it usually has infiltration of the dermal lymphatics. It presents with this orange peel appearance, as I said earlier on. You can see so now a darker skin patient, and then this is a fairer skin patient. You can see the nipple retraction in this patient as well. Yeah, so they may not have a palpable mass because, again, it's inflammation, it's diffuse, but diagnosis is made based on clinical findings. So it's a warm breast, it's red, it's edema, and then treatment is by modified radical mastectomy with chemotherapy and radiation. So you see it's triple therapy. Prognosis after 5 years is 40% in the Western world, and it could be as bad as 10% in low and middle income countries. Now, the thing is, with inflammatory breast cancer, it's always classified as T4 because it involves the skin. So you can see how, stage 4, you can see how far the tumor, how severe and how aggressive IBC is. So how do we stage breast cancer? So all invasive breast cancers are tested for estrogen and progesterone. Those are the hormones and HER2 receptors, yeah? Which I'll show what HER2 receptors are shortly. Then you have clinical staging that's based on the tumor size, lymph node involvement, and metastasis. So basically your TNM, yeah? Your tumor size, lymph node involvement, and metastasis. Now, receptor status helps guide treatment decisions. So are we going to treat with hormones or not? So HER2 positive, which is an epithelial marker, yeah? And I'll show you exactly, require targeted therapy. Yeah? It's a tyrosine kinase sort of therapy. And then triple negative cancer, so that means they are negative for estrogen, negative for progesterone, and HER2 are primarily treated by systemic therapy. You give them the chemotherapy. So this is receptor testing. So this is HNE, this is hematoxin and eosine. This is estrogen receptor, this is progesterone receptor, and then this is HER2. So you can see, so here we have, it's positive for estrogen and progesterone. So you can see how it stains positive there, then negative for HER2. So this is hormone positive. Then here it's positive again for estrogen, it's positive for progesterone, and this is positive for the epithelial marker there. Here it's negative for estrogen, negative for estrogen. Here you can see how it stains differently. And then here as well, and then here it's positive for HER2. So this is HER2 positive. And this is triple negative. So negative for estrogen, negative for progesterone, and negative for HER2. Good. So based off that, so we said we have your hormone receptor positive cancers. So these hormones, we said, are estrogen and progesterone. Okay. Now, if it's so by description, so what we've seen, so immunohistochemically, it shows that greater than 1% of the tumor cells are estrogen receptor and or progesterone receptor. Percentage-wise, most of them are usually estrogen positive, some are both, 70%, and some are hormone receptor negative. So the thing is, if it's positive, then you may want to consider endocrine therapy. I mean, you consider endocrine therapy, but then some may need chemotherapy depending on how advanced it is. And it's common in postmenopausal women. For the HER2, so that's human epidermal growth factor receptor 2 positive patients, the tumors stain positive for HER2, and this requires immunohistochemistry, as we've seen here. So this is immunohistochemistry. So it's stained with that antibody, or sometimes fish, yeah, and see the hybridization, or yeah, for confirmation. Then this accounts for 20% of the cancers. So in this case, you want to do chemotherapy and HER2 targeted therapy, and this increases the risk. And I mean, this type of cancer has an increased risk for metastasis, so that's something you need to consider. Then you have those that are triple negative. So those are tumors that are negative for estrogen, negative for progesterone, and also negative for HER2. About 15% higher incidence in Black and Hispanic individuals. In these patients, you can't do endocrine therapy or hormone therapy. So in this case, you have to do chemotherapy. It's associated with BRCA mutations and a high recurrence risk. So a patient comes with triple leg cancer or IBC, yeah, you're worried. So you can see 70% of the cancers are hormone receptor positive, 15 to 20% are hormone receptor, HER2 positive, and then 10 to 15% of the cancers are triple neg. So clinically, so you said you can divide it into the tumor size, the nodal involvement, and metastasis. So stage 0 is TIS, yeah, and it's in situ like DCIS. And if you start with T, so TX is when it's not accessible, you can't examine the size of the tumor, let's say the breast is not there. For example, there's a mastectomy that happened. T0, there's no evidence of primary tumor, then TIS is carcinoma in situ. Now, when you have a tumor and you measure it, yeah, if it's less than 2 centimeters, that's T1. And then that's further subclassified depending on the size. If it's between 2 to 5 centimeters, it's T2. Greater than 5 centimeters, that's T3. Now, when you have a tumor with direct extension, all right, to the chest wall, that becomes T4A. To the skin, like I showed you in IBC, that's T4B. Then T4C would be both the chest wall and the skin, and then T4D. Sorry, yeah, T4D actually should be inflammatory breast cancer. Apologies, yes. Then for your nodal involvement, so NX is when there are no lymph nodes you can regionally that you can assess, maybe there was dissection, and then NO when there's no lymph node involvement. Then it's further subclassified. Not to go into the details, but yeah, N1, N2, N3. MX when you can't assess distant metastasis, MO when there's no distant mets, and then M1 when there's distance detectable metastasis. That's histologically proven. So based off that, you can then divide your cancer into TIS. So stage 0, stage 1, that's early breast cancer. Stage 1, stage 2, that's early breast cancer. Stage 3, that's locally advanced breast cancer, LABC. And then stage 4, that's advanced breast cancer. Advanced. So with the moment you have M1, distance metastasis, that becomes stage 4. So treatment is multidisciplinary. So it includes surgery, radiation, and systemic therapy. We have neoadjuvant therapy for locally advanced tumors. So basically, you radiate the tumor, it shrinks, you put a pin in it because it can shrink and then gets lost. Then afterwards, you do the resection surgically. You have adjuvant therapy, that's post-surgery to prevent recurrence. And then you have fertility preservation for premenopausal women. Systemic therapy includes chemo, endocrine therapy, or a targeted therapy. So how do you manage early breast cancer? So early breast cancer is basically cancer that includes tumors that are less than 5 centimeters in size without clinically positive lymph nodes. So if you have a small tumor, lymph nodes are negative. You can't feel them clinically. So what are your options? You can do surgery. So when you're doing surgery, you can do breast conserving surgery. So you can do a partial mastectomy or a lumpectomy, or you can even do a total mastectomy. The guys who do prophylactic mastectomies, let's say, for example, they have the BRCA1, 2 positive, They have a positive family history of breast cancer. So what they do, they have both their breasts removed and their ovaries. So they do a BSO. Axillary lymph node management. What you want to do, you want to do a sentinel lymph node biopsy. So that's a fast lymph node that drains the breast. Yeah. Then you can do axillary dissection if more than 3 nodes are positive. Yeah, and these are the indications on this other side. You can do chemotherapy in this patient, so systemic chemotherapy based on the stage and the molecular profile. Now, in this case, so that means if you're triple neg with a tumor size greater than 1 centimeter, or HER2 positive, tumor size greater than 1 centimeter, or high risk hormone receptor positive tumors after genomic testing, that's when you do chemo in these patients. Radiation therapy happens after BCS, that's breast conserving surgery, in some patients. And mastectomy patients need radiation only in high-risk cases. That's in early breast cancer. So it can be done after BCS. Tumors greater than 5 centimeters, there's chest wall invasion, and more than or equal to 4 nodes or 4 more nodes are positive. We can also do hormone therapy, so anti-estrogen or aromatase inhibitors, things like letrozole for hormone receptive, for HR positive tumors. And then you adjuvant to you give chemo first before surgery to shrink the tumor, and then now you excise. Then you have locally advanced breast cancer. So these are tumors that are larger than 5 centimeters, or those with clinically positive lymph nodes. So in these patients, surgery is an option. So you can do breast conserving surgery or total mastectomy, depends. So contraindications to BCS in locally advanced breast cancer include if the tumor is large, if there's just body involvement, if there's multifocal disease, or large tumor to breast ratio. Your lymph nodes are also very important. So you want to do auxiliary dissection for clinically positive lymph nodes and sentinel lymph node biopsy for clinically negative nodes. Indications, so clinically positive, and a clinically positive axilla requires this dissection regardless of chemotherapy response. But then you can also do chemotherapy where you shrink it neoadjuvantly, so before surgery, and then it also helps eradicate micrometastases and also assesses the response. So in this case, the tumor pathology needs to be done. So you need to report the positivity. That's your hormone receptor positive. How is it HER2 positive? Is it triple neg? In those cases, you can also do radiation therapy in these patients and hormonal therapy depending on what you get with your on your pathology. For metastatic breast cancer, it's already metastasized. So you can do systemic therapy. Systemic therapy in this case is your chemo, targeted therapy, immunotherapy. Yeah, so you have your PD, we call it PD something inhibitors. Yeah, or hormonal therapy, depending on the molecular profile and fitness. And this is based on the tumor characteristics again and the patient health. You can do palliative radiotherapy where you basically shrink those primary tumors because sometimes they can grow very large. Could be in the brain, it's so huge. It could be in the bone, it could be in the lung. So you do it symptomatically to relieve the pain, the obstruction, and this focal neurological deficits. Again, surgery is not curative, but then again, it's for symptom control and palliative care. We might have something that you can have a very huge liver mass that obstructs the second part of the duodenum, and then you have indigestion in issues like that. So surgeons can go in and resect a bit of it. All right. So we've talked about BCS. So it's basically wide local excision with clear margins. It's preferred for early stage non-metastatic breast cancer. Then it's followed by radiation therapy. So adjuvant, it augments. Contraindications include multicentric tumors, inflammatory breast cancer, and in some cases, you can have the nipple areola complex being resected. Mastectomy, so this is removal of the entire breast. It may include the axillary lymph nodes, depending on whether they're involved or not. Indications have extensive tumors, high-risk patients, and depending on the patient preference, whether they want the whole breast removed or not. So types include total mastectomy, skin sparing, nipple sparing, or modified radical mastectomy. You could do a prophylactic mastectomy for high-risk patients with BRCA mutations together with their ovaries, the BSO, bilateral salpingo-oophorectomy to remove the tubes the fallopian tubes and the ovaries bilaterally. Then you can do breast reconstruction at the time of surgery. Lymph node management. So this is standard. You want to do a sentinel lymph node biopsy. That's the first lymph node that's drained, that drains the breast. This is standard for early breast cancer. Then you want to do axillary lymph node dissection for more advanced cases. But the thing with this lymph node dissection, remember, it's draining the lymphatics of your upper limb. You may have lymphedema as a complication, but generally SLNB is preferred to avoid these complications. And then lymph node neoadjuvant chemotherapy may alter the lymph node management, whether or not you want to dissect them out or not. So radiation therapy in breast cancer, this is as an adjuvant. So you add it on after doing your breast conserving surgery. It's used in locally advanced breast cancer, LABC, or to control metastatic sites. It typically targets the remaining breast tissue and the regional lymph nodes just to make sure, it's completely eradicated. Sometimes you can do palliative radiation, radiotherapy, as I said, and it's contraindicated in pregnancy and certain connective tissue diseases. So you may have a lady, she's pregnant, she has breast cancer. Depending on the trimester, if it's early in the trimester, she may be advised to terminate the pregnancy. If it's way advanced, then it's wait. So you don't want to radiate such a lady, or even do chemotherapy, depending. So it depends. So chemotherapy in breast cancer, so I said it's used for triple negative, HER2 positive and high-risk hormone receptor positive cancers. So basically all patients who are HER2 positive with tumor sizes greater than 1 centimeter should receive anti-HER2 directed therapy. Triple neg patients with tumor sizes of greater than 1 centimeter should receive systemic chemotherapy. Again, neoadjuvant chemotherapy may shrink tumors for surgery, and common agents include anthracyclines like your doxorubicin, but then remember doxorubicin is also cardiotoxic, taxanes like paclitaxel, and then chemotherapy regimens are tailored to the specific tumor type and stage, and can cause your normal, side effects, your alopecia, your nausea, your immunosuppressions, and get infections and stuff like that. Yeah, so when it comes to type of chemotherapy, I really don't want to go into the details because it's going to get a lot. But anyway, we have cytotoxic chemotherapy, targeted therapy, immunotherapy, and hormonal therapy. Cytotoxic chemotherapy, it's used in your adjuvant or adjuvant settings, effective in high-grade tumors like triple negative, HER2 positive. Targeted therapies target specific proteins like HER2, like trastuzumab or pertuzumab, your PARP inhibitors, CDK4/6 inhibitors. Immunotherapy, things like pembrolizumab that act on the PD-1, PD-L1 pathway, so they dampen the immune response. And then hormonal therapy, things your SARMs, your selective estrogen receptor modulators like tamoxifen that are given for like 5 years, and your aromatase inhibitors like letrozole. Endocrine therapy. Sorry, I know this has taken way more than I should have expected. But anyway, we're almost hanging there. Endocrine therapy in breast cancer. So it's indicated for hormone receptor positive breast cancer. Premenopausal women, you want to give tamoxifen or ovarian suppression with your GnRH agonist. Postmenopausally, you want to give your aromatase inhibitors, your anastrozole, your letrozole. And it's administered for 5 to 10 years to reduce the recurrence risk because these hormones help with the proliferation. Estrogen really helps with proliferation of epithelial cells. Side effects include menopausal symptoms because you're blocking out your estrogen, osteoporosis, and your thromboembolism. Now, this is your HER2 positive or targeted therapy. So this is an uncancerous cell. Look at the HER2 receptors. So what happens? They're stimulated. As I said, it's a tyrosine kinase receptor, and then it results in normal cell growth and division. Now, in this case, your receptors are so many, and then this leads to your proliferation, and then it then leads to the cancer that you're seeing. So targeted therapies block these receptors to prevent activation, and it inhibits the growth of the tumor, the proliferation of the tumor. The problem with this therapy, like trastuzumab, is we have a risk for cardiotoxicity. So it requires monitoring. So in such patients, you want to make sure you get serial ECGs. Other agents include lapatinib and trastuzumab whatever that is. Okay, and then HER2 targeted therapy improves survival in HER2 positive breast cancers because I mean, if you work on it, it blocks that proliferation. So that's why it's important to ask for these receptors. Complications of breast cancer treatment. So surgery related, you'd have lymphedema, you could have long thoracic nerve injuries, you have a winged scapula, chemotherapy, immunosuppression, alopecia, nausea, fatigue, endocrine therapy, hot flashes, thromboembolism, bone loss, osteoporosis, radiation, fibrosis or wherever you're radiating, skin burns, and pneumonia. I don't know if you guys have seen people who've been radiated, especially in their head, usually have this like black patch on their head. And then pneumonitis. Long-term risks of secondary cancers also pose as a complication, like radiation-induced angiosarcomas. Briefly, we have male breast cancer here, accounts for 1% of all breast cancers, normally presents with a painless retroareolar mass with nipple changes. You can see here there's nipple retraction. Retroareolar just means behind the areola. Most common type is hormone receptor positive, HER2 negative invasive carcinoma. Risk factors include BRCA2 mutation, Klinefelter syndrome, and estrogen exposure. Treated with surgery, endocrine therapy, and chemotherapy, depending on what the tumor characteristics are. When do we screen ladies for breast cancer? Depending on the guidelines, you want to start your mammogram as early as 40 to 45, some would even say 35, some even 30, every 1 to 2 years, depending on the guidelines. Then clinically, a clinical breast exam is not routinely recommended, again, depending on the guidelines. Mammography is safe. Apologies. Mammography is safe during pregnancy with a lead shield. So if in pregnancy you're suspecting a lady to have breast cancer, they have a lump that's suspicious, you can do a mammogram. Especially in the third trimester, you can do one. Then breastfeeding women should pump or nurse before mammography. Yeah, because with radiation exposure, then you have your side effects, your fibrosis, blah, blah, blah. Yeah. But then now, depending on the guidelines, so this routine self-examination is not recommended. Now, in this case, what the rationale I think is because women, depending on the phase of the cycle, they may have lumps, these benign lumps, depending on the cycle. But then what should be recommended is for them to know what is suspicious of malignancy and what does not look malignant. But then this needs to be coupled with the mammograms they're doing yearly. So screening for high-risk individuals. So you want to start mammography and MRIs at the age of 25 for BRCA mutation carriers. Women with prior radiation exposure, you want to do annual screening starting 8 years post-radiation. You want to do tailored screening screening based on the family history, genetic mutations. Then high-risk women may benefit from prophylactic surgery. So you can do your mastectomy and your BSO. And then for those who are really young, because you're starting really early at like 25, an MRI is recommended. Risk-reducing interventions like surgery. So you can do prophylactic mastectomy where both breasts are excised. And this reduces the risk by up to 90%. You can do a BSO, remove both the breasts and the ovaries. And this is recommended for BRCA mutations like Angelina Jolie. And risk-reducing surgeries are considered for those with strong family history, and follow-up care is essential post-surgery for psychological and physical well-being, especially the breasts. Cosmetically, it's a huge thing, especially for people who can't afford reconstructive surgery. Yeah, it's an issue. Lymphedema is a complication. You can see the size. This is really edematous, and this occurs after axillary lymph node dissection or radiotherapy. So you have this swelling, tightness, and limited arm mobility. The risk increases with the extent of the surgery and radiation. It's usually managed by manual lymph drainage and compression therapy. And then there's also a long-term risk for angiosarcoma and chronic lymphedema. You have your paraneoplastic syndrome with breast cancer. It's uncommon, but you may have patients have hypercalcemia, syndrome of inappropriate ADH secretion, or Cushing's syndrome. And this is basically a result of the secretion of the ectopic hormones or the cytokines. But often, these paraneoplastic syndromes usually improve once you treat the cancer. So you need to have supportive care alongside the primary cancer management. In terms of follow-up and survivorship in breast cancer, We want to do regular clinical exams every 6 to 12 months for the first 5 years, and to do annual mammograms for those who had breast-conserving surgery, surveillance imaging for high-risk patients. You want to monitor for recurrence and metastasis. You may want to do CTs and MRIs and address psychological well-being and quality of life in survivors. In terms of prognosis, it's caught at stage 0, survivor, 5-year survival rate is 100%, stage 1, 100%, stage 2, 93%, stage 3, 72%, stage 4, 22%. But then remember again, this is all dependent on where this is diagnosed, where it's managed, whether you have underlying comorbid factors, the age, whether you have social support as well. Thank you very much. This is my email in case you have any questions. I'll take a couple of questions as well, and that's my LinkedIn if you want to follow me on that as well. Thanks.
Okay, next up we have Dr. Wangari. And I think we'll have our question and answer session towards the end after the Kahoot. So Dr. Wangari, please. And that was a lovely, lovely presentation. Mohamed, amazing. No words.
Thank you.
Dr. Wangari?
Hi, sorry. Can you hear me?
Yes, yes.
Okay. Hi, I hope we're still excited and still, eager to learn. So, yes, thank you for. Can you guys see the poll? Okay, so this session is actually meant to be interactive. So, nataka tuongeleshane. Yes, so the question is, if self-care was a superpower, which of these topics would you want to have? Yeah, sorry, which of these would you want to have? I'm seeing ability to instantly relieve stress. Okay. To make healthy food taste like favorite dessert. Yes, I would also like that. To instantly boost your energy, that caffeine. Okay. 1 more minute left. Okay. You guys don't want to just fall asleep anywhere, anytime. Okay, no, that's dangerous. You could actually be sick. Okay. So I think, lovely. I think we can now begin. So I'm seeing most of us would want to instantly relieve stress with a single deep breath. I know, right? Sawa. So, Felix, if you could help me present my, present my presentation. Yes, okay, I can see it. Yeah, so we're talking about the fun stuff. Mohamed alikuja the technical stuff, which is also really important. And thank you, Mohamed, for that. So yeah, I'll be speaking about holistic care in cancer. My name is Dr. Wangari. Getting used to that title. Hiya. Next. Yeah, and now that we're talking about holistic care, I'm honored to have founded a holistic supportive cancer care called Warrior Glow, where we take care of patients, teach them how to deal with side effects of treatment. So to be relevant to the month about breast cancer, we make breast prosthetics for patients who, undergone mastectomy. Yeah, we also have fun stuff. We have Zumba classes where, we generate endorphins and we stay fit. We have several activities that we do. Please check out our website and our social medias to see more of what we do in that community. Yeah, okay. Next slide. Okay, we've already done that. Next. Lovely. So, in case you're wondering, what is holistic care? So, it's care that involves you treating the person as a whole and of the disease. So, the body, the mind, the spirit. I feel like even from the presentation we've had, there is a lot of emphasis when it comes to medicine and treatment on the physical aspect, the medical aspect, which is now the first component. So the chemotherapy, the surgery, the radiotherapy, which is actually really, really important. But there are other components of, taking care of a patient as a whole person. So we have nutritional support, because it's from what we eat that to an extent our bodies are able to be healthy or not. We also have emotional and psychological support. Cancer is a big thing, There's still so many people and so many places where stigmatized. So there's that bit of it. You get a diagnosis and people are just like, hi, him, and we also have physical activities. One of the things Mohamed mentioned is lymphedema, a complication of, the lymph node excision that happens during surgery. So, however, there are particular tailored exercises that, that can be used to just help reduce that. But even just generally, there tends to be muscle weakness. And there are exercises that are there that can actually help. So we have complementary therapies, we have yoga, acupuncture. Most of them, I'm sure you're wondering, is that really part of medicine? But they actually add, and there are studies to show that they are effective. The social support. I mean, you need a community, all the way from diagnosis to treatment. So there's that, the spiritual care and palliative care. I actually would say that our work in Warrior Glow, mostly what towards or who is moving the slides. Also, can you guys hear me? Kidogo kuna a little background music, but I hope I'm still clear. Yes, give me something. I like it when it's
We can
interactive.
hear you. We can hear you.
Sawa, thank you. So, as we journey through this, I want us to think of holistic care like a beautiful garden. I have provided us with a picture. So each plant represents a crucial aspect of recovery, from the vibrant flowers, that could symbolize emotional support, social support, to the strong, sturdy trees that represent the physical health, and the nourishing soil that represents the spiritual well-being. So you see how it's not just one thing; it's very multidimensional. So that's what holistic care, comprises of. Next slide. So, in case you're wondering, what are the benefits of holistic care? So, one is an improved quality of life. Again, an example, in places where there's stigma, having a social support really, really does make a difference, because we know how a patient feels, and stigma tends, where there's stigma, the results are likely to be, the outcomes are likely to be negative than positive. We also have enhanced emotional support. You have better pain management, because apart from pharmacological support, there are other ways to manage pain, even like relaxation techniques and other things. We also have increased patient empowerment, strengthen social connections. That's in the context of spaces, where we provide support groups. And, we can bring in patients together and they can share their experiences and, they can encourage one another. Yes, they live there, just feeling empowered and connected. There's also improved coping mechanisms. Again, cancer, unlike many other diseases, can feel very, very isolating. But incorporating holistic care, people are able to come together, like, for example, in the support group. So they're able to share, for me, when I was experiencing this is how I dealt with it. For me, when I got the diagnosis, this is how I had that conversation with my friends and family. And that way, we're able to share healthy coping mechanisms, because you're able to tell someone, this is what worked for me, this didn't work for me. And, better lifestyle, because we are able to, share, like I mentioned, nutritional support, physical exercise, all that, and then reducing treatment side effects. higher, the next thing. So yeah, another analogy, holistic cancer care is like building a house. You need a strong foundation. In this case, it's the medical treatment, and Moha has beautifully explained and broken down and mentioned all the options that you have in terms of medical treatment. So you need that to build that house. But the structures also need the walls. So you need a roof, you need the windows, you need the furniture to make it livable. And that's what these other components of holistic care um, come in. So I just want us to really, really see how important to have a holistic care approach in taking care of patients, particularly cancer patients. I have the next one. So, what is the progress in integration in Kenya? I mean, yay, it sounds nice, okay. So, are we doing it? And if we are, to what extent? So, once there's increased awareness in that, we know more people know about it than they knew before. So, that's good to be. And I mean, look at us, we are here having conversations about it. Two, there's emergence of supportive services. So, hospitals like the Nairobi Hospital, Aga Khan, they provide services beyond the medical treatment. I know there's support groups, even in Kenyatta, yes, they do have support groups. They have nutritional counseling, they have psychological support. So that is good. We also have CBOs, you have organizations such as Cancer Kenya, Cancer Foundation of Kenya, we have Kilele Health Kenya, I mean, we have Warrior Glow, we have all these spaces now, where they address these other aspects of care for the cancer patient. And then for palliative care development, there are more hospices now, and there are more palliative care facilities. Not enough, to be honest, not enough, but more. In fact, they were not there before, but at least they're there. 5, we have integration of treatment plans. I know, for example, in Kenyatta, they have this system called the navigation system. So once you get a cancer diagnosis in the social service department, you get to see a navigator. So for the navigator, one, they get to explain to you, so umeambiwa you have this type of cancer, for example, now breast cancer, and then they'll be able to, inform you where to start. Because as you've seen, treatment, there's a lot, and it's different per patient. There are patients who have chemotherapy and radiotherapy without surgery. There are others who have surgery, only the others who have all of them. So, they get to guide you. So this is how your treatment will look like. You're going to do this and this. And, they also get to connect you with like a nutritionist so that they're able to advise you. So this, I would say it's an improvement. It's a really, we're in the right direction. So yes, that is the 5th point. However, there are some challenges because we're not there yet. We're really not there yet, in my opinion. So the first point is training and education. I mean, I just cleared my medical school, and honestly, there wasn't so much emphasis on these other aspects of taking care of the patient. There is more emphasis on the medical part. But the rest, psychosocial, the nutritional, there is little to no information about it. And that takes me to the next point, the fragmented healthcare system. Our healthcare system is viewed to be very, again, still very medical. And so even me as a doctor, how I have been changed to practice is, come, I get your diagnosis. Okay, you do the test, I get the diagnosis, I prescribe the medication. That's it. My time is done. I do not put in a lot of care, to ask myself. So, what's their mental space? I do not put a lot of care to, give advice on this is the best food for you to eat. These are some of the adjustments you can make to your lifestyle. Really, it's really not incorporated. There are also financial limitations. yeah, if you're being honest, all these things cost money because one, you need professionals to do it, and you need some of these resources to do it, you know. Even if we are saying that there's a particular massage, acupuncture, you need facilities to do this. So this needs money. So there's also that. And then there's cultural norms and perception. To an extent, it doesn't feel medical enough. It feels like, all right, this is sub-medicine, you know, like let other people do it. It's not dactari enough, it's not serious enough. And because of that, you know, again, we are conditioned to think that as long as I have taken care of the medical aspect, that's enough, that's important, that should be enough. However, it actually isn't. And then there are time constraints. I mean, okay, I've been having conversations about mental health in work spaces, especially in health. And one of the challenges is, very long hours. So if you're seeing really many patients, there's only that you can do. And it makes sense that the best you can offer is just the medical treatment. So that's also another systemic challenge. We also have limited resources. We have lack of evidence-based practices. Again, due to the fragmented healthcare system and the cultural norms and perceptions, even research that is done is not, we don't really focus on these other aspects of taking care of the patient. And to a great extent, doctors are the type of people who work with facts. Show me the numbers, show me the studies. But again, who's doing the studies? So if we're not doing the studies, we're not getting the numbers. And if we're not getting the numbers, you're not going to implement it. Are you seeing how it's such a vicious cycle? Guys, are you seeing it? Yeah, and also there is patients preferred. I mean, the patients don't know that, they are entitled and they should be able to get this other, aspects of treatment. And so for that reason, once they get the therapy, they get their surgery, they're good to go. And they won't inquire further because they don't know about it. But others also feel like, I really don't need that. But eventually they find out that they actually do. Okay, so the next slide. So what is a practical support, or rather, what is a call to action? Personally, I am a believer that you just don't stop at the problems. Like, yeah, these are the challenges, but the conversation should never end there because I feel like it leaves one at a space, at a space where you just feel hopeless and helpless. And I think that really is not it. So, what are some of the practical ways that we can be able to, do something about this, so that at the end of the day, the quality of care that we give to our patients is good? So, yes, one, education and awareness. And I think we're already doing it. I mean, in this platform, in case you didn't know about holistic care, you now know. And now that you know, share with other people. And I think it's up to us to start amplifying, this message. So that's one of the ways. And so, yeah, kudos to XYZ Baby. You guys are already doing a good job. The second thing is, clinical rotations and internships. So I remember in med school, we did all these rotations and everything, but if it was not for my involvement in Mohamed, I honestly wouldn't know about, like something like the social service department. I wouldn't know, the journey that patients, go through or take beyond me writing a diagnosis that yes, you have breast cancer, and I feel like most people don't know. So maybe it's a challenge to us. Can you find out what other things are going on in the hospital? These other departments that do not feel very clinical to you. It's a reason why they're there. It's a reason why they're part of taking care of the patient. So yeah, just find out if you can intern in some of these organizations and things that, address other aspects of patient care so that you're also conversant with it. I mean, at the end of the day, you want to be the best doctor that you can be for your patient. You want to be the person where after a patient sees you, they're just like, yes, just up and eye, it's there's no one better. So that thing is research and advocacy. As you know, I shared, one of the challenges is we have very few papers, or we lack evidence-based support, or you know, the benefits of holistic care. So in spaces of research, hi Moha, and anyone else here who they enjoy and do research. Maybe this is also something you can also explore. I know in Warrior Glow we are currently working on um, two research papers, and I think it's a start in the right direction. By the way, you guys are also welcome. We have a whole research department, and yeah, part of you committing to be a holistic, health provider, and they're interested in research, come and join us. And let's start changing things so that they work for us and our patients. Higher. The fourth thing is interdisciplinary collaboration. I am not in any way expecting you to provide all this support. And so that means that there needs to be a team behind you to be able to provide this support. Again, I feel like this is something we need to learn as early as possible. I really don't think med school, prepared us enough to work in multidisciplinary teams. But again, we can always learn because we want to provide the best care for our patients. I mean, that involves there being multiple people, they need to learn that. So, having a nutritionist on board, having a physiotherapist on board, even having the chaplaincy on board, because you say spiritual care is also important. That's something that we're really, really intentional to grow in Warrior Glow, just to have different disciplines, different students in different courses, just coming together and bouncing ideas off of each other. I think one of the things that I learned that was really fascinating for me in my PhD was the different determinants of health, from social determinants of health. It's helped me, see health in a whole different way, that it's not just one element. There's a lot to it, and there's a complexity to it that is beautiful. In this case, it also involves a team. So that's one of the ways that you can be able to be relevant. And then finally, personal development, because if you're talking about, like a social support, you can only pour from a cup that has something. So you also need to be mindful. You need to, you're advising someone to eat healthy. It's only right, actually. It only makes sense that you're also eating healthy. So there's also that bit. There's a bit of you that even for you to offer, that's holistic care. So yeah, that's the practical support and the call to action. And in conclusion, again, another analogy. Health is like a garden, and just like a gardener will nurture the plants, there is the trimming, even actually from the beginning, there's planting the seed, there's watering it, there's providing the right environment. And once it grows, there's the pruning, there's the putting the manure fertilizer. It's not just one thing. That's the main message that I want us to see. In taking care of our patients, whether it's cancer patients or other patients, but now in this case, it's still relevant because we're talking about cancer patients. It's not just one thing, it's a whole ecosystem that is achievable and that actually has results. And when we choose to implement and we're able to bring in all these different aspects, we have a holistic patient and we're able to be holistic healthcare providers. Yeah, that's my conclusion. And thank you. Are there any questions?
Well, if there are any other questions, like I think we will do them after the Kahoot. That was a beautiful, engaging session, Dr. Wangari. Sorry, Dr. Wangari. Sorry about that. Um, I was face palming when I said that out loud. But so now comes like the most interactive part of our session today, and it's time to see like what everyone has learned from today's very, very interactive session. So please download the app if you haven't, if you're new, that is. And the game pin is 9576138. We are waiting for you to join. www.kahoot.it, or you could alternatively scan the code on the screen as well. Join, guys. It can't just be the four of you. Umang, Verlerly, Thomi, Luch, Kulo, I think Kulo is, yeah. Angela. Okay, then let's start with our first question. Which of the following genetic mutations is most strongly associated with hereditary breast cancer in younger patients? TP53, APC, BRCA1, and HER2. BRCA1. Let's see. Salatov is currently number 1. Which of the following do you believe are key components of holistic cancer care? Physical health, financial support, emotional and social support, all of the above. Yes, all of the above. NM is currently leading. Which subtype of breast cancer is more likely to be multifocal and bilateral? Invasive ductal carcinoma, medullary carcinoma, invasive lobar carcinoma, tubular carcinoma. None of you got that one. It was invasive lobular carcinoma. Degwa is still on the lead. Which is the primary factor that differentiates ductal carcinoma in situ from invasive ductal carcinoma? Presence of lymph node involvement, penetration of the basement membrane, hormone receptor positivity, and expression of HER/NEU. Yeah, penetration of the basement membrane. Nice. Degwa is still on the lead. What barriers do you think prevent holistic care from being fully implemented? Lack of awareness and insufficient resources for healthcare workers, focus on traditional medicine over holistic care, limited resources or funding, or all of the above. Yeah, all of the above. Husseina, number 2, NM, number 1. Mel isn't playing. In the management of breast cancer, sentinel lymph node biopsy is recommended for which of the following scenarios? Inflammatory breast cancer, early stage breast cancer without palpable lymph nodes, triple negative breast cancer with distant metastasis, hormone receptor positive for breast cancer with axillary lymphadenopathy. Early stage breast cancer without palpable lymph nodes. Dagwa has 3 correct answers in a row, so he's on a streak. Histological finding in rapidly growing breast mass, well-circumscribed lymphocytic infiltration, BRCA1 positive. Medullary carcinoma, Paget disease of the breast, tubular carcinoma, invasive lobular carcinoma. Medullary carcinoma. Dagwa still in the lead. Which group do you think should play a bigger role in providing holistic cancer care? Oncologists and doctors, nutritionists and dietitians, nurses, healthcare support staff. Yeah, all of the above. Question 9, screening for breast cancer in a woman with a family history of breast cancer in first degree relative should begin after 30 years, age 50 years, 10 years before the age of the earliest diagnosis in the family, at 40 years, regardless of family history. Yeah, it's supposed to be 10 years before the age of the earliest diagnosis in the family. But every year. Yeah. Solotov is number 2, NM is still in the lead, and Hussein number 3. Which of the following is the first-line therapy for hormone receptor-positive breast cancer in postmenopausal women? Aromatase inhibitors, trastuzumab, tamoxifen, and chemotherapy. Aromatase inhibitor. NM in the lead. We see you. Which is a major complication associated with the use of trastuzumab in patients with HER2 positive breast CA? Hepatotoxicity, cardiotoxicity, nephrotoxicity, and neurotoxicity. Cardiotoxicity. In the context of triple negative breast cancer, which of the following statements is accurate? It is more common in postmenopausal women. It is associated with BRCA1 mutations. It has better prognosis than hormone receptor positive breast cancer. It is primarily treated with endocrine therapy. It is associated with BRCA1 mutations. Yes. And I'm in the lead with a streak. That's the last question. Which of the following findings on mammography would most likely indicate a diagnosis of ductal carcinoma in situ? clustered microcalcifications, skin retraction, and nipple inversion, well circumscribed round mass, diffuse breast thickening. The answer is clustered microcalcifications. Thank you so much. Number 3, Husseina. Number 2, Solatov. And number 1, Degwa, or NM. I think he's been frequently attending sessions and is always in the lead. Any other questions for Dr. Wangari and Mohamed? I believe the session was very, very well done. Yeah, very interactive. Learned a lot. Any questions, guys? Okay. Please follow our social media pages. We have a Spotify podcast, YouTube channel, and WhatsApp channel. And we also have like a research project. It's on the link. Please access it via this link. It's placed on the chat. Also, yeah, I just wanted to say, like, I think that Warrior Glow is a very good initiative. And they have like research work ongoing, and I think that would be really good, especially for young medical students that are, like obviously pursuing further. Research is a really good skill, and it's a really good thing to have on your CV. I don't think I have any other thing to say, except thank you so much, Mohamed and Dr. Wangari and XYZ Med. Keep the good work going. Thank you.